Hello, hello to our faithful followers. It's that time again where we are doing a live and we are talking to apologies, not doctor. We are talking to Claire Julsing-Strydom today. She is a registered dietitian and she is joining particularly relevant to women. So before we start, and while we're waiting for Claire to join us, what are hormones? Essentially, they're the body's chemical messengers. So they're the body's chemical messages, and essentially messengers, and they send messages from one part of the body to the other, and these messages govern pretty much most of the functions in our body. So for example, when your body needs fuel, it's a hormone that lets you know that. When you need sleep, it's a hormone that lets you know that too. And your growth, emotions, reproduction, and general well-being are all impacted by hormones. And this is a topic that's particularly relevant to women, purely because men have hormones too, but it's not unique to us women. But we do tend to be mostly impacted because of the various life stages that we go through. So just give me 1 second. So I'm just going to invite Claire again. We seem to be having a little bit of a technical problem. Here we go. Just sent another invitation. And obviously one of the things that's, hi Claire, lovely to see you.
Good in you.
Good. So I've just been giving a quick introduction to hormones, but to be fair, I feel like I'm a little underqualified to do that. So to kick off, I'm just going to ask you to tell us a little bit about yourself, and then I'm going to hand over to you to tell us about hormones, because I think you're probably going to do a way better job than I did.
So thanks for having me here today, Lorna. My name is Claire and I'm a registered dietitian. I've been in practice now for 19 years actually this year. And yeah, a long time. And I love working with women who have polycystic ovarian syndrome. That's really my area of expertise and interest. So yeah, that's what I do on my day-to-day basis. I'm based in Johannesburg, in Bryanston, and I work with a lovely group of dietitians at Nutritional Solutions. So yeah, that's a little bit about me. And I myself have PCOS. I think that's probably also why I'm so passionate about working with women who have this condition.
Fantastic. Thanks for that. So let's dive straight in. I can see we've got lots of people joining, so let's get to the heart of the matter. First question, what are hormones and why are they so important?
So hormones are basically like little chemical messengers in your body that relay communication throughout the body. Think of it like a cell phone network with towers, okay? They need to speak to each other if you're trying to phone. Like hormones work in so many different parts of your body, from your gut to your brain, to when you sleep, to when you eat, to when you feel full. There are so many regulatory little messages being passed throughout your body all the time. I mean, just when we were talking more about this, I was reading, and the hormones just never, there's so many, Lorna. Like I was saying to Lorna, I was looking at my physiology textbook, and there's tons of hormones. I think we sort of delve into the hormone side when it comes to female health and menopause and puberty and those, which we'll chat about, but it's on every single level. You cannot believe how hormones are interacting all the time.
Yeah, I mean, and so one of the other trends we're looking at is circadian rhythms. Yeah. And there's definitely an impact there in terms of hormones as well, and hormones telling you kind of like when to go to sleep and that kind of thing. And it's I'm sure we'll get into it later, but there are so many like things, for example, that I didn't know were hormones. For example, you told me that vitamin D is a hormone, and I almost fell off my chair because I was like, but it says vitamin in the name, why is it a hormone? So that's
a vitamin, but it basically acts like a hormone. So yeah, even me, when we learn new things all the time, right? But vitamin D does act like a hormone. It has multiple impacts. It acts on ovulation, especially in PCOS. It has major roles to play. It helps to downregulate inflammation. So yeah, insulin's a hormone. You've got the ghrelin, the leptin, the cortisol. These are all hormones. Those aren't even discussing the hormones around menopause, puberty, menstrual cycles. So it's very, very vast. It's quite it's like how long is a piece of string. That's how many hormones there are in the human body. It's quite extensive.
Okay, so I think for the purposes of this conversation, we are going to focus in on three main areas. But before we get there, I'm going to ask you to take us through sort of a whistle-stop tour of, especially for women, the different life stages we go through and the impact that hormones have at those life stages. But just for everybody that's tuning in, just so that you know, the main topics that we're going to be covering today are cortisol, which is the stress hormone, or is a hormone that regulates your reaction to stress, if I'm understanding that correctly. And it's something that affects a lot of women. And the second thing we're going to be covering is PCOS, because as Claire mentioned, she is really a specialist in that area, and it's something that's relevant to a lot of our customers, especially women in their 20s and 30s. So we really thought that would be an interesting topic to cover. And lastly, we're going to be covering menopause as well, because it's certainly becoming a topic that's coming out of the closet. Women are talking about it more. So just so that everybody's aware, those are kind of the three main things we're going to be talking about. But first, our whistle-stop tour, like I said, of the different life stages and kind of for women, and what your hormones are sort of doing at each of those.
So if we take the female picture, the biggest sort of point for us where I think hormones become something that comes onto the radar is around our menstrual cycles, when we start puberty. Mm-hmm. And when it starts, we get increases in estrogen, increases in follicle stimulating hormone and luteinizing hormone, which are the ones that make us from a girl into a woman as we start these menstrual cycles. And we then continue, and I think a lot of focus gets put onto then the next stop at pregnancy and fertility, and when we want to fall pregnant. And in the PCOS space, a very large portion of women battling with infertility have PCOS. So that next step is really around pregnancy and fertility and ovulation. And then from there on, we carry on and we go to the menopause phase. And I think if you didn't have fertility issues, certainly by the time you get to menopause, you're like, what are hormones? How do they work? How can I fix this? How can I stop the night sweats? Because then the estrogen and the progesterone just completely go down. And that throws us into a whole nother ball game, which we'll get into a little bit later, and the knock-on effects that those shifts in hormones then have. So I think those are like the three key pillar areas in female health. Also, obviously, during pregnancy, when we carry babies, our hormones are also important, our HCG, our progesterone, and we get oxytocin, we get prolactin that makes breast milk. So every single stage of human health, every single stage has hormones involved. We've just sort of dipped into key aspects of them, Lorna, like those main pillar ones, I guess, like you said, the whistle stop tour.
Yeah. I mean, look, the reality is that if we were to go into the detail of all of this would be a 3-day live. And we've got about half an hour to 45 minutes, so I think we need to keep it short and sharp. But I think hopefully that's a really good sort of example. And I saw that there was a question there about which supplements we should be taking. So I'm going to ask that person to maybe just repost that question a little bit later, because we can't quite get into that now, because we're sort of going to focus first on cortisol, then we're going to move into PCOS, and then we're going to move into menopause. So when we do get to the relevant point, please do pop that question in again. And guys, if there are any other of you that have any specific questions on what Claire is saying, please do feel free to pop them in the comments as well, and we'll try and answer them as we go along. Right, so let's talk about cortisol. And as I mentioned, it's a particularly important hormone for women, especially with the stressful lifestyles that we have nowadays. Cortisol is getting a lot of airtime because of its impact on the body, and the sort of fact that stress seems to be throwing cortisol out of whack. So I guess the first question is, what is cortisol, and what is it for our body? And once we've covered that, then we'll kind of move on to what causes imbalances, what are the symptoms, how do we treat it? But let's start with what is cortisol and what is its function in our body.
So cortisol is a stress hormone essentially, and it's released by our adrenal glands, which is just above the kidneys, basically.
Oh,
Yeah.
yeah, those are lymph nodes. Sorry, ignore me. Listen to Claire.
And those are the same ones that release like adrenaline, noradrenaline. When if you're getting chased by a lion, they are going to release. So it's like your fight and flight hormones, and yeah, cortisol to help you respond to stress and danger. That's like its main job. Okay, so that's the main job of cortisol.
Okay, and so how does cortisol get out of balance?
Okay, so the thing with cortisol, it's like the Goldilocks hormone. Okay, it's got to be not too high, not too low. It's like got to be just right. Okay, so you can get imbalances in both directions. So we often see people, from a medical perspective, that have high cortisol if they're on corticosteroids and for prolonged periods of time. The other thing that happens is when we have prolonged periods of stress for prolonged, that can affect your cortisol. It can go high or low, okay? But once that cortisol is out of balance, it really has quite a knock-on effect and different symptoms.
So let's talk about those symptoms. So just to kind of recap what you're saying in layperson's terms, essentially cortisol can get out of balance through two main causes. One is prolonged or chronic stress, and two is sort of repeat use of corticosteroids. Okay, but the more common one is probably stress, because that's something that we all kind of
medical reason that you're going onto cortisone for long periods of times. The main reason that most of us we working, we mums, we careers, it's like go, and we're so used to that we just think that's the norm, and it's actually not. So what starts happening is, when your cortisol is out of balance, you can feel extremely fatigued. You can even get nausea, vomiting. You can get weight loss. You can get weight gain. You also get muscle weakness. You can get cravings, depression, weakened immunity, are all symptoms that are related to cortisol being out of balance.
And it affects your sleep patterns as well, right? Because from what I've seen, cortisol is sort of like it's a graph during the day, and it's supposed to peak and dip at certain times throughout the day. And what happens when your cortisol levels get out of balance is that they're sort of dipping and peaking at the wrong time. So that can often lead to that yeah. And then that feeling that they call it tired and wired.
Yes.
You're exhausted at night, but you can't fall asleep because your cortisol levels are not where they should be at that time of day.
Yeah. So definitely big link in terms of cortisol and your circadian rhythm is definitely one of those areas. And if we look at what can we do to now help us rebalance that cortisol, and when we are getting stuck, like what are the steps that we can take? Okay, so there's a couple. The first thing is you've got to look at what's driving that stress the whole time.
Yeah, you start with the root cause, right? So because it's obviously the cortisol, I mean, you can treat the cortisol imbalance presumably, but I mean, the best way to treat it to deal with the underlying cause, which is the stress.
And something of interest to note, I was reading a really good article, Lorna, last year, and what it was saying is, when we are stressed, and it can be perceived stress, okay? So even if you are stressed about a work deadline or an exam or your child starting a new school, whatever it is, your body can't differentiate the stress that you are experiencing or if a lion's actually chasing you. But when we are stressed, our body will actually even redistribute energy utilization during stressful periods. And one of the key things that happen when the cortisol is not doing what it's supposed to do and our stress levels are high, it redistributes energy utilization, and we store fat as a protective mechanism. So often when we are wired and tired and our cortisol is not where it should be, we also start to gain weight. So weight gain also becomes one of those issues. And the things that we can do to start helping here is we've got to reduce the stress and figure out what those key causes are and try to address them. Also just even thinking about stuff the whole time and letting your mind sort of run away with you. If it means you need to do yoga or Pilates to calm down, whatever helps you, or seeing a psychologist or medication, whatever it is, you need to take those action steps. We know from a dietary perspective, things like caffeine and alcohol and stimulants can make the cortisol worse. So look, there are the individualized sort of differences there. Some people can still get away with the caffeines, etc. But for the majority of us, we've got to pull back on alcohol, we've got to pull back on caffeine. And then one of the helpful things from a nutrition perspective to help with those stress hormones and the cortisol is to have an anti-inflammatory diet and reduce inflammation, and actually eat foods in our diet that help to down-regulate inflammation, because cortisol is already actually driving higher visceral fat, higher production of inflammatory cytokines. Okay, so our inflammatory cytokines,
I was just going to say, please tell me what an inflammatory cytokine is, because I'm a little lost.
So inflammatory cytokines are like little markers to go, like, hello, we're on fire here, can you call the ambulance to come and help us? And these inflammatory cytokines happen when there's a stress response and there's damage, or there's oxidative stress, and now we get an inflammatory response. So your body has to tell the body, hello, we need help. And that's like calling the immune cells. I always say to my patients, it's like it's like somebody phoning like the little 911 and saying, come help. It's your inflammatory markers go up, and then you're going to get an immune response to try and sort out that inflammatory response.
Regulate the
For inflammatory cytokines, they're quite a lot. There's ferritin, there's interleukin, there's tumor necrosis factor. We can get it. There's a whole list of them, okay? But we know from a nutrition standpoint, there's certain things that help to down-regulate inflammation. And those key things are a diet high in fiber, because fiber down-regulates inflammation, and omega-3 fatty acids in the diet. So through dietary sources, through supplementation, can help to down-regulate inflammation. And then a diet really rich in phytonutrients. So most of us are not getting enough phytonutrients into our diet, and we get those from eating a variety of color from vegetables primarily. But other things that people forget about are things like curcumin and ginger and mint and nutmeg and cinnamon. So yeah, herbs and spices and veggies, and you know, we get stuck in like a little routine where we go butternut and then spinach and then tomato and lettuce and cucumber, and we just buy these things on repeat, and we're not getting that variety in our nutrient intake. So I always encourage my patients, and if you are somebody who's particularly stressed and you're going through a rough time and you know your cortisol is not good and you're feeling almost puffy, sometimes you start feeling puffy from the inflammation as well, you want to increase those phytonutrients. So making vegetable soups or having just raw veggies that you can snack on at your desk. You know, I think we sometimes overthink how to get the veggies in, and we just need to simplify it. So even just, you know, putting cinnamon on your pumpkin already increases your phytonutrient intake, because you're layering up with more phytonutrients from herbs and spices as well. So those are other key ways that you can try to reduce the cortisol.
Okay, so it's really about variety of nutritional intake. Yeah. And that doesn't mean like pizza, bread and rolls. It means like, as you know, that the whole like eat the rainbow, as people say. So it's really about trying to get as many different fruits and veggies in, all of which are going to kind of contribute different phytonutrients. And for everybody wondering, phytonutrients are basically just vitamins and minerals, right?
No, so phytonutrients, you get micronutrients, which is like your vitamins, your minerals. That's vitamin A and vitamin B and vitamin C. Then a level up from that are these little, so those are micronutrients, okay? And there's vitamins and minerals. Phytonutrients are like the chemical compounds in food types that are going to elicit a response in the body. So let me give you an example. You'll all be familiar with beta carotene. It's the color that, it's the one that orange color to carrots and pumpkin and stuff. And your granny would have told you, if you eat your carrots, you'll see in the dark. Okay, now that's true because of the beta carotene in the carrot, and that phytonutrient actually helps with the retinoid in the eyes specifically. You get lots of different phytochemicals. So you get things like resveratrol, which reduces total cholesterol. Okay, it actually has that property, and that's in purple colored, like blueberries are high in resveratrol. We always see people take garlic supplements or those kind of things in wintertime, and they work. And the reason that is because garlic, onions, leek, fennel, those very strong allium vegetable category, are rich in disulfides, and disulfides improve your immune function. So your phytonutrients are those chemical compounds, and it's often in groups of colors of different veg. It's more like a rainbow, say, compared to like a dairy category for calcium, if that makes sense, just to try and categorize it. But there's over 2,000 different phytonutrients. I mean, we've just mentioned 3 now. There's thousands.
Okay. Thank you for explaining that, because it's always not been that clear to me. I see one of the questions that came up is, what should we eat for fiber?
Okay, so fiber, South Africans, we are typically not that great at fiber. We need to be better at it. So how you do that is, the best advice I can give you is start looking at your labels, okay? Get a pen and paper out and write this down. You want your fiber to be higher than 6 grams per 100 grams. If the fiber on the back of the package is lower than 6, it's not a great fiber. It's not high in fiber. You've got to start looking out for things that say, this is a multigrain or this is whole grain. That does not mean high in fiber. Okay, you've got to check your labels. So examples of great fiber-rich foods are things like bulgur wheat. It's got about 18 grams of fiber per 100 grams, which is really great. You get rice, like a brown rice, could have about 9 grams of fiber, but you've got to check brands. Within different brands, you can have double the fiber just by choosing a different rice. So look at the back of labels when you're in the shops. And go for the highest fiber that you possibly can get in. Legumes are also a very good source of fiber. Your bran, like a shredded bran or an oat bran, are also good sources of fiber. So if you can do a combination of those things, you're going to get fiber from fruit and veg, but not as much as you're going to get from like the barley, the bulgur wheats, the spelt, the bran. And you need 25 grams a day if you're a female, and 38 grams of fiber per day if you're a male.
Sure. And it's, that's quite a big, so you need to eat your way through quite a lot of salad to get to that.
So just to clarify, Lorna, you will never meet your fiber requirement from veg and fruit alone. It's impossible. You need about 15 cups a day of veg and fruit to reach fiber intake from veg alone and fruit alone. You have to eat whole grain carbohydrates that are unprocessed, that are whole grain, that have got that whole, if you take a milli and you pull it off and you hold it up to the light, you'll see like a round thing and another round thing and then the corn. That's called the germ, the endosperm, and the grain. And that thing, when it's intact, is a whole grain and provides fiber. So we've just got to go look at our labels a bit more and pay a bit more attention, and also look at brand differentiation and choose options that are higher in fiber. But a simple switch to make is switch your normal white rice to like a barley or a bulgur wheat. You've almost tripled your fiber by doing that simple switch. Put lentils into your mince. You've increased fiber. Instead of having a muesli, add oat bran to the muesli, or switch those little changes like that can have a big impact on your overall fiber intake.
Fantastic. So I think hopefully we've now kind of like covered that. And I see there are quite a few questions coming through, but guys, they're not, what I'm going to do is those kind of more general questions, I'm going to ask you to park until the end, where we kind of will do a general Q&A, because we're trying to sort of stay on the topic now. So I think we've covered cortisol. The next one that I wanted to cover is PCOS. So let's kind of talk about that. PCOS obviously being closely linked to fertility. So the first question there is, what is PCOS or PCOS, depending, different people pronounce it differently, and what are the common symptoms?
Okay, so PCOS is a endocrine metabolic disorder, often mistaken as a reproductive disorder. It only has reproductive outcomes, but it's not actually a reproductive disorder. It's an endocrine metabolic disorder. And what happens with PCOS, we typically see higher androgens. So it's one of the male pattern, it's a male sort of more dominant hormone, and that goes up. And how do we know if we have PCOS? There's 3 key clinical signs and biochemical markers that you can look for, because unfortunately it's often misdiagnosed, and most women will see 5 doctors before they get their PCOS diagnosis.
Okay.
So if you're not sure, I'm gonna list them, and if you've got 2 of the 3, it's very likely that you have PCOS. So if we have anovulation, so you're not getting periods, or your period is shorter than 21 days or longer than 35 days, that would be considered anovulation or longer periods. Then if you have cysts on the ovaries, which they can do with an ultrasound. You can also have PCOS without having any cysts on your ovaries. Okay, so if you just have, you might not have cysts, but you might have periods every 40 days, then you still have irregular periods because you're out of that sort of category. And then the third thing is it's biochemical, which means your blood test, or clinical symptoms of hyperandrogenism. So what that means is high androgen levels either on a blood test, or you get acne here. You see acne in the lower area of the chin. You get hair growth here and here. So we get male pattern hair growth, male pattern hair loss. We also see weight gain as another symptom of PCOS, but around the androgens in particular is you see the acne, you see the hair growth, you see the hair loss. So you can test it, but I can often see PCOS sitting in front of me without a blood test when you can see the acne, the hair, the hair loss. With insulin, which is another part of the PCOS, you get darkening here in the neck, in the arms, in the groin, darkening of the skin. You get skin tags as well, like they look like little small, like I want to say like a wart, but like a little skin tag is another clinical indication. So if you're sitting there and going, oh my word, Claire's saying that, I'm going, yes, 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 go and see someone to help you and see if you actually do have that diagnosis.
And who should people typically see to support them with that kind of diagnosis? Is it a GP? Is it a gynecologist? Is it a nutritionist?
Very question, Lorna, because you hit the nail on the head, because you could go to, this is what happens. This is why people go round and round. They go to the dermatologist because they've got the acne, or they go to the gynae because they're skipping their periods, or they go to their GP because they're gaining weight, or they go to the endocrinologist because they've got no signs. So any one of those specialists or GP could diagnose you, but you almost have to, I think it's really important for us as women to go and say, look, I've got this and this and this symptom, and I really do think it's PCOS. Because if you go and you only say I've got acne and you're not describing others, you'd want the medical profession to ask more leading questions and find out what's actually going on. So for example, as a dietitian who has a very special interest in PCOS, and I work with 90% of my patients have PCOS, and sometimes people will come to me and go, I don't know if I've got PCOS, and I'll do bloods and I'll go, you have hyperandrogenism, you're skipping periods, you need to see the guy, I need to check for cysts, but clinically you have it, but I'm not a diagnostician. So I would refer the patient back to the medical practitioner to manage the diagnosis, but then work with the patient going forward to look at their sleep and their stress and their eating and their hormones and their nutrient deficiencies, and start to correct this over a period of time and shift those habits. And you're dealing with high hormones, nutrient deficiencies, insulin resistance, glucose intolerance, so thyroid issues as well. So it's a complex mix, and you get different phenotypes within the PCOS picture as well. So it is individualized, and it's quite tricky to sometimes get a diagnosis for that exact reason of who do you actually go see.
Okay. So I would imagine that a functional medicine doctor, because they tend to take a more holistic and integrative approach, could be a good person to seek out for a diagnosis like this.
Medicine doctor would be a good idea. I mean, yeah, I work with amazing gynecologists as well. So it's just finding the right person. And I think if the alarm bells are going off for you right now and you're not sure, you can also just DM me and I can guide you and say, that's a great doctor in that area, or, you know what I mean? Often people will ask me. So I'm very fortunate. Where I work, I've got lots of gynecologists that are very clued up about PCOS. So when they see a patient, they can get the diagnosis sooner than later, which helps. The sooner you start treating the condition, the better it is for the patient.
Yes. And as with all medicine, you know, I'm guessing that one case of PCOS does not present like another. And you mentioned something about phenotypes earlier. I'm not quite sure what that means, but I'm guessing that it sort of talks to different hormone levels and, you know, specific kind of elements around like how you would treat the PCOS slightly differently from one patient to another. Do you maybe just want to talk about that a little bit more?
So some ladies would be more, there'd be more sort of prominent anovulation, or they'd have cysts, and some don't have cysts. Others have got more nutrient deficiency. Others are more clinically, there's strong insulin resistance, or they have, there's big issues with inflammation, for example, or there's also a thyroid condition together with the PCOS. So you do see different phenotypes and different classifications. You also get lean PCOS, where somebody's not overweight at all, but they have PCOS. So it's, yeah, so there's most women with PCOS will battle with insulin resistance. The majority will have insulin resistance, will battle with weight gain. So that's your typical, more common picture, can I say? But you definitely get the other phenotypes that practitioners working with PCOS should be aware of. Because, Shame, I mean, often the lean PCOS patient just gets sort of pushed aside and said, no, but you're not overweight, so don't worry about it, or come back when you want a baby. Those are comments that get made, and actually that person still needs to be treated. It's not just to be left until one day when they want to have a baby.
So one of the questions that we got there is if it was necessary to take glucophage. So I'm going to come back to that in a minute in terms of the treatment. But before I do that, so please let's just remember that. But before we do that, one of the questions that sort of came up for me is like, what causes PCOS? Because I think we've gone into the detail around like, you know, how you know you have it, what the potential symptoms are, how you should seek out a diagnosis. But for those people that maybe don't have it yet, like, is there something that they should be aware of in terms of, you know, taking certain steps to prevent PCOS onset later?
So we don't actually know the exact cause of PCOS. It's probably a more genetic profile. And from my understanding is that in like previous times, having PCOS would have been a protective like phenotype or a protective genetic situation where you wouldn't fall pregnant, you'd store fat better, so you wouldn't get hungry as much. If you're thinking of like hunter-gatherer cave type.
Okay. So it was basically keep women safe.
It was like a good thing to have it then. But now you take those genetic predispositions, and also if you've got family history of PCOS or family history of diabetes, you have a higher risk. But you now take those genetic predispositions and you put them into our obesogenic environment, and it just exacerbates everything. And we're seeing this in so many other chronic conditions as well. Our environment definitely is an obesogenic environment. I was on a call this morning with a very well renowned professor, and he was saying the reality is, we were saying, well, why has obesity changed so significantly? And the reality is we live in an obesogenic environment, which means if you're not making an effort to be well, you will by default be ill.
Sure, that is so scary. Just the fact that our modern world is engineered in such a way as to actually make us unwell. And so it's this effort on our parts to work against that, to kind of work towards wellness.
It is like that, yeah, it is.
Sure. Okay, so I think we've covered sort of how you know you have PCOS, potential causes, although that's not entirely clear, but there are some kind of risk factors. So let's talk about once you have the diagnosis, what can you do? Understanding, and we've already covered the fact that, you know, it presents differently in different women, and there may be sort of different complexities from case to case, of course. But generally speaking, you know, what are the things that people with PCOS can do to improve their situation and improve their symptoms?
So one of the first line treatments in PCOS is the use of inositols, and that's been shown to really help with PCOS management. So what's very important though, when you take an inositol for PCOS, you should be taking a combination of myo-inositol with D-chiroinositol, and that ratio is really important. It's a 40-to-1 ratio, especially in the fertility space with PCOS, because the wrong ratios there can actually have a negative impact. We often also use insulin sensitizing drugs like metformin, which is the question that came up, or glucophage are used. The only thing to be aware of there is if you are on those medications, that specific drug has a drug nutrient interaction where it reduces vitamin B12 and you become deficient in B12. So if you take glucophage, metformin, any of those sort of class of drug, you have to take vitamin B12. That's also really important to understand. Something that's very common in PCOS as well is nutrient deficiency. So you need...
Before we move on to the nutrient deficiency, I just want to kind of clarify. So inositol in general seems to be helpful for the treatment of PCOS. However, there is a lot of detail and specifics around the type of inositol and the ratio in which you should be taking them. So this is definitely something best navigated with a medical professional.
Definitely, because you don't want to, especially if you're trying to fall pregnant and you're taking the wrong types or the wrong dosages, it can actually have a negative effect. So we don't want to do harm, right? And also the thing is, if you're taking inositol in the wrong dosage, you're not getting a therapeutic effect. So you go, well, I did inositols, they didn't really work, and now they don't work for me. But actually, we now know there's systematic reviews and meta-analysis that show that inositols are a first-line therapy now for PCOS. You can use combinations of inositols with the medications like a metformin together because they work differently. So you can use them in combination. A lot of patients just get put on the pill immediately, which is not always necessary. However, there are instances where a patient hasn't had a period for such a long time that we actually have to put them on some kind of hormone to get a menstrual cycle, because that buildup of the lining starts increasing risk for cancers if we don't do that. So it's important that when you work with someone in the PCOS space, they need to have, I work with a team of other doctors, so that if I know if this patient's not in the pill and we're not having a cycle, they have to see the gynae as well. We have to regulate it from different parts. It's like a little bit of a spider web. Shame, I don't want to get into all the nitty-gritties, but it's really important that you work with a team that deals with PCOS every single day.
Okay, so it's not necessarily, so once you have your diagnosis, it may mean working with a combination of doctors and nutritionists, so possibly a gynae and a nutritionist, sorry, dietitian, and a dietitian. But so I guess that leads quite nicely into the next thing that you were going to mention around nutrient deficiency, and that is obviously something that working with a dietitian on is extremely helpful. So let's talk about that.
So we know with PCOS, just example for magnesium, if you have PCOS, you have a 17-fold increased risk for magnesium deficiency.
Wow, that is huge. Okay.
So we often see low levels of magnesium, B12, vitamin D, and then often iron also goes bad, because the reality is often these ladies, they can also have very, very heavy periods, prolonged periods, and they're losing blood. So we often see anemia as well presented in these patients. And often, Lorna, I'll measure bloods with these patients and they're deficient in all four. Or they've been on a long extended period of metformin, and they weren't aware that they had to take vitamin B12, so they're completely deficient. So they're feeling exhausted from having PCOS, but they're also exhausted because they have a vitamin B deficiency, B12 deficiency, and they're exhausted because they're completely anemic. And the poor person is like finished. They can't exercise, they can do nothing because they are just flat. So you have to look at PCOS holistically from all these different angles.
Okay. And obviously, looking at those nutrient deficiencies, it does sound like blood tests kind of seem to be part of the treatment regimen, because obviously you need to kind of get a baseline of like where those nutrient levels are. And, you may, to your point you mentioned earlier, that there may also be some blood tests required to actually get the initial diagnosis. So that's probably going to be part of the process at some point as well.
There's no way around it. You have to go for blood tests in this condition, because there's just too many variables that differ from individual to individual. And you've got, like, just an example, vitamin D. You can't just go give 10,000 IUs of vitamin D if you don't have a baseline and know where you're working off, because you can get toxicity in that particular vitamin. So you can't just, there's no like thumb sucking. You have to do bloods. So yeah, I think it's important for people to understand, once you've done the bloods and you understand which areas you're more prone to have an issue with, we can redirect further testing later on to look at those specific areas in future. You know what I mean? Like, we know, okay, you had a vitamin D of 7, we need to recheck that in sort of 3 months' time and see if we're having an impact with our intervention.
Yeah. And I mean, look, I guess the reality is that one of the like amazing things about living in this day and age is that you know, all of these things are relatively accessible. And I mean, look, it's never fun being poked in the arm with a needle, but to be accessible, like by medical aid for the most part. And you know, it does kind of give your clinicians the detailed information that they need in order to really give you a personalized treatment plan and help you recover.
Yeah, because it's critical. If you don't know those levels, you can't actually treat the condition effectively.
Fantastic. So I think, was there anything else that you wanted to mention about PCOS that you think is important?
You'll have me here the whole night. So it's like if you do have PCOS, it's my main thing. So you can follow me and I'll give you lots of advice on PCOS. But Shane, we can go to menopause, otherwise we'll be on PCOS forevermore. I'll never finish. So, yeah.
Follow Claire's tips. You can check her out at dietitian Claire on Instagram and TikTok. So, right, menopause and perimenopause. What is it, and common symptoms?
Okay, so menopause is basically 12 months after your last period, and it's a time leading up to that point. So it's changes in your menstrual cycle, hot flushes. We see a drop in estrogen, a drop in progesterone, and this normally happens between the ages of 45 to 55, and it lasts about 7 years. It can last longer, but it's about a 7-year process. So if it's going rough, you don't want to be stuck and feel terrible in that process, you know what I mean? And I mean, so we know we get alterations in bone metabolism, our lipid metabolism changes, our risk for cardiovascular disease unfortunately goes up. We also have changes in body composition and how we store fat, we drop muscle mass, all related to that drop in estrogen.
So that kind of tells me that if you are heading into that period, you probably are going to have to do much more physical activity to kind of restore that muscle mass. Just kind of not knowing much about the subject, or, you know, but there's already kind of a few things that I'm picking up that, you know, those changes are going to have to changes in lifestyle if you want to kind of get back to your baseline, I guess.
They actually published a big systematic, like a big paper last year in the Lancet, because there's been such a fear around using hormones and HRT for a long time, which has also been a bit misguided. And I'm not a medical doctor, so this is not my area of expertise, but I can just tell you what's in the medical literature, right? Okay.
So for HRT is hormone replacement therapy, right? Okay.
So we actually know now that most women are going to need hormone replacement, because what we're seeing is that women are not getting treated with hormones in those perimenopausal spaces, and that's in that earlier time when you're ready to start seeing the brain fog, the fatigue, you're getting hot flashes, and you're like, oh, I'm sure it was just because it's like a hot heat wave here in Joburg. You like sort of like want to write it off. I mean, I've got a friend that's 40 and she's in menopause. She's in full-on menopause. So you've got to check that. They've got to check your levels, and there are now different types of hormones that are being used at different stages of cycles, and it's really, you absolutely need to get a practitioner that can help you with this, because your risk for cardiovascular disease goes up, your risk for Alzheimer's goes up. There was just, I mean, it made the news in the last week about how having HRT is actually reducing the risk for Alzheimer's.
Wow.
Using menopause. So we're seeing big papers come out in this space, I think, just to clarify things from the past that aren't maybe 100% accurate. But so definitely you need hormones in menopause. There's not really a way around it. So if you're a bit fearful of that, get a practitioner that you can work with that can actually measure your levels and guide you. Because I mean, you might be in your later 40s and need progesterone at the end of your cycle every month, but they need to measure that. And there's so much more advancement in medical science now than when our moms were going through menopause, that we can actually have our hormones tested. They can track exactly which pathways our hormones are traveling in terms of our nutrigenomics. I mean, it is incredible, and we don't have to suffer through this anymore. There's modern medicine now to help us with menopause.
Which is amazing. And I think the other thing that I'm starting to notice is that there's also much more of a conversation about this, because it's been this very sort of silent thing that women don't really talk about. There's not much conversation about, you know, maybe it's like a punchline and a joke about older women, but it's not really talked about. And I think that's starting to change, and there's sort of much more, and I think that's amazing, because the benefit of that is that women are understanding, to your point, that they don't have to suffer in silence, that actually there are these treatments available. So let's go straight to the chase. So you mentioned, you know, get a clinician that can assist you with this. Is it, what kind of doctor? Is it an endocrinologist? Is it a functional medicine doctor? Who is best placed to support with this kind of thing?
I mean, yeah, you definitely want a functional medicine, or a endocrinologist is also great. There's also gynaes that are great with this. It's really about finding the right doctor, because you do get, I can tell you this, if your doctor says, no, you can't go on HRT, you're going to get breast cancer, run far away. That's not correct at all, okay? Get a new doctor. But yeah, you do need hormones. And so your gynae, an endocrinologist, a functional medicine doctor, they need to be testing you. They can't just give you hormones. They need to actually do tests. If they're not doing tests, that's like a big red flag for me. If they are saying, oh no hormones, you'll just, it's okay, it's just menopause, you're just a bit hot. Those kind of like gaslighting patients.
Oh yeah, we've had doctors like that have told us that our symptoms are psychosomatic.
Not good. So, I mean, again, if people need recommendations, there are clinicians that I work with that are amazing and are just really clued up. You want to, when you be dealing with stuff like this, find out when you phone the offices of that person, does this person see menopausal patients every single day? Is it like an interest of theirs? That's the person you want to see when you're in this space.
Wow, that's actually super helpful. Very practical.
Like if you phone my office and you say, how often does Claire see PCOS patients? I'll say 90%. I see a PCOS patient 10 a day. You know what I mean? That's what I do every single day. So find those people, because they're reading up, they're passionate, they're working with those patients all the time. They're on top of the science in that space. Remember, medicine's massive. It's hugely broad. So if you're dealing with a particular issue with your own health, find the practitioner that has a special interest in that area and that works in that area predominantly. Then you're going to just, it's going to just make the whole journey a lot more better and more successful for you.
Wow. Okay. That's really practical and helpful advice, Claire. So I think we're kind of getting to sort of the time where we need to kind of start wrapping up and getting general questions. So I've seen a few questions coming up. There was a question about, you know, who can you recommend for PCOS and hormone imbalance in Cape Town. I don't know if you want to kind of recommend somebody now, or if you'd rather DM that person.
Yeah, that person can literally DM me. They can just pop me a DM and I'll give them a little list and see where they're based and try and guide them as to who to refer to. Happy to do that.
Yeah, it's because it's not a case of one size fits all, right? And I think that's just the benefit of medicine today, is that there's, you know, like there really is somebody, like a doctor or a medical professional for every kind of person, and finding your tribe that's going to help you through these hormonal issues is really, you know, and often it's so it takes a village to raise a child. It also takes a village to get a woman through PCOS and menopause, I think, and the right, you know, the right tribe and the right village in terms of, you know, for you personally, because that may not look the same for you as it does for somebody else.
100%. No, you're 100% right. And it's also nice because we have access to so many more people because of virtual. That was the one benefit of COVID. We all do virtual now. I'm in Joburg. I see patients in Durban and Cape Town and London and all over the show, because we now do virtuals so much more.
Telehealth. True. So I'm just going to ask anybody to drop any final comments in the comments. And while we're doing that, Claire, is there anything else you kind of want to add on this topic of hormonal health? I mean, I know that's super broad, but anything else you kind of want to finish off on?
As a dietitian, because just a few things on the menopause, vitamin D, omega-3 was very helpful in menopause because of those increased risks in cardiovascular disease and inflammation.
Yes.
Use as the final thing on menopause, you need to get your muscle mass up. Your muscle is going to drop as you get older. It reduces by 8 to 10% from the age of 30 on an annual basis. If you're not making an effort to maintain muscle mass and doing resistance training, that is busy tanking.
Did not realize that much. That is quite scary.
Yeah, it's estrogen with the resistance now in the 40s. That's what it means. So the other thing is that just as a dietitian, every single one of these menopause, PCOS, if you can just get some key, like the inflammation is apparent through all these stages, the risk for chronic disease goes up in all these stages when there's dysregulation in hormones. So if there's 3 things you can do that will be an anti-inflammatory benefit in your diet: high fiber, omega-3 fatty acids, 4 cups of veg a day with herbs and spices to increase phytonutrient intake. Do those 3 things consistently, and it will already put you in a good position for your overall health.
Wow, that sounds great. I'm actually going to ask you to repeat that, because that sounds like really great advice in general for fighting inflammation, which goes beyond PCOS and menopause. So can you just say that again, please?
It's increase omega-3 fatty acids. So you want to eat things like sardines, pilchards, mackerel, salmon, trout. If you on a vegan diet, get an algae omega-3 supplement. You just want omega-3. You don't need all the others. Just the omega-3 is great. On the fiber side of things, make sure that your diet has 25 grams of fiber per day for a female, 38 for a male. Check your labels. The higher the fiber, the better. Look at the 100-gram values on the back of the pack. So bulgur wheat, barley, spelt, those millet, they're great high fiber sources. And the last thing is big veg, big veg, 4 cups a day. Doesn't matter how you get it in a soup, roasted, raw, eat it like a bunny, doesn't matter. Get the veg in, lots of color, add herbs, add spices, because that uplifts the phytonutrient composition from foods in your diet. So those are the 3 things.
Thank you for repeating that. So we just got a question from Erica Wasserman, or Wasserman, sorry, not sure how to pronounce it. How will changing your diet help if you are suffering from PCOS? And how will the first online session go?
So if we look at your diet with PCOS, is if you don't have adequate fiber in your diet, your inflammation is going to be higher, number 1. Number 2, we need to look at your protein throughout your day and how your glucose is going. Because if I see a lot of women with PCOS are skipping breakfast, or they're trying to do variations of intermittent fasting, it's actually making the PCOS worse, because now they've got high inflammation already. Now they're under eating. They're not meeting their nutrient requirement. They're actually gaining more weight. Most women I see are under eating with PCOS.
Wow, interesting.
They just get told, cut, eat less, exercise more, you're overweight because you're just using your PCOS as an excuse. This is stuff that gets said to women with PCOS. It's crazy. It's actually shocking. But most of the women, I mean, I saw one of my patients today and she's lost 6 kilograms of fat mass, and we started in December. So she's done that over the December holidays. And she said to me, Claire, I've never eaten this much food in my life. So I said to her that this is exactly it. You were never meeting your basal metabolic requirements. Something else to consider with PCOS and diets is that women with PCOS typically have a higher muscle mass. So their basal metabolic rates are higher and their nutrient requirements are often higher. So we can actually assess that. We actually do body compositions with patients. We look at visceral fat. We look at muscle mass. We identify what areas we're going to be working on with that individual patient. We look at nutrient deficiency. So if there's an issue with inflammation, we will increase omega-3s in the diet, because we want to get food sources of those nutrients higher in the diet. We want to use magnesium in the diet to help people get better sleep when they go to bed at night. So it's a collection of many different things, Erica, and it really depends on your individual requirements as well. So it doesn't help I just go, that's the diet for PCOS. There isn't the diet. It depends where you at, what you're ready to change, what your bloods look like, what your insulin levels are like. Those will all have an impact on what we're going to do from a dietary intervention perspective.
Great. Thank you so much, Claire. So I'm not really seeing any other questions coming up, so I think we are going to end it there. Anything else you want to end on before we end off this topic of hormonal health at every life stage?
I just, yeah, it's so important that you know what your levels are and you get your person that's going to look after you during these life cycles, ladies, because you're going to go through them, they're coming. You need the tribe there to support and help you. And then obviously big veg. That's like, if people said, if you can just get the good stuff in. Someone said, Claire, if you could make a billboard about nutrition, what would it say? And I said, it would say, get the good stuff in. Stop worrying about all the things you can't eat. Get the veg in, get the omegas in, get the fiber in, get the good stuff in.
Oh, thank you so much, Claire. This has been really helpful and super practical. Yeah, we are going to, for those of you that aren't aware, we will be posting this on YouTube afterwards. So you are more than welcome to go back and have a look at all of these pearls of wisdom, because there certainly were many today. Thank you very much for your time, Claire. We really appreciate it.
It's a big pleasure. You must have a lovely evening. Bye.
Cheers, Claire. Bye-bye. Bye, everyone.